Welcome everyone to Unmasked, Racism and Discrimination as Determinants of Health Equity. My name is Marina Chand, and it is my great pleasure to welcome you all here tonight, and also a warm welcome to our online participants. We've had about 400 people register online, so it's very exciting for our first event. So tonight's event is a collaboration between Monash University, the Australian Multicultural Health Collaborative and World Wellness Group. I'm the co-chair of the collaborative together with Mohammed Al-Kafaji from FECA. And I'm also one of the co-founders of World Wellness Group. We're a health service based in Brisbane. So I would like to acknowledge the traditional owners of the land on which we are meeting. I understand that the land on which Monash University is built was traditionally occupied by the Yalukit Willem clan of the Bunurong people. The Bunurong people were part of a much larger alliance of 5 Aboriginal tribes, together forming the Kulin Nation. I pay my respect to elders past and present and acknowledge all Aboriginal and Torres Strait Islander people here tonight in the auditorium and also online. And I also acknowledge that we are on unceded land. This is also an opportune time to express our unequivocal support for the Voice to Parliament and the Uluru Statement from the Heart. This powerful statement eloquently and truthfully tells a story of collective experience and the structural nature of this collective experience. The call for truth, fairness, self-determination and justice is one that is long overdue. We could not hold an event that unpacks racism and discrimination as determinants of health equity without acknowledging this historic event, the upcoming referendum, where we can all play a role for a better and more just future for all Australians. So a bit of an event rundown. So tonight we're really fortunate to have 3 leading speakers with considerable expertise in health equity. You'll have an opportunity to ask questions after all the presentations. So for our online participants, you've got a Q&A box. So please pop your questions into the Q&A box and we will keep an eye on those and make sure that those get asked at the end on your behalf. So just quickly, why we have put on this event tonight. I just want to share a little bit about World Wellness Group. So we are a not-for-profit health service working for health equity for migrants, refugees, and people seeking asylum. So we run a social enterprise medical clinic, and we also deliver wraparound services, mental health, allied health. We also have a number of phone lines, and we also undertake health promotion. So since day one, when World Wellness got started 11 years ago, we made tackling health inequity our mission. And we have welcomed people seeking asylum since day one in our clinic, regardless of their Medicare or visa status. In our first 10 years of operation, we've delivered more than $1,055,000 worth of pro bono and unfunded healthcare. So we basically fundraise to maintain this pro bono work. And the struggle to maintain our work is actually really real. Medications, pathology, radiology, etc. are really expensive, and our services are in high demand and running at full capacity. So if you donated during the registration process, thank you so much. We really appreciate it. It actually directly sustains that work. And if you haven't had a chance to donate as yet, we would still love your donation. And I think a link was already sent to you by email. So I guess in honor of the people who are actually structurally locked out of the health system that we service every day at World Wellness Group, we have put this event on to expose racism and discrimination as the driving forces behind health inequity across the globe and in Australia. The collaborative is the multicultural peak body, which is the multicultural voice in the health system. And it's working at a systems level for health equity and justice for multicultural Australia. Post the COVID-19 pandemic, there is a lot of talk about health equity across Australia. We need to have an advanced understanding of systemic racism and discrimination to tackle this health inequity if we truly want to achieve equitable health outcomes. We have therefore brought together international experts to share their research and their reflections with us, personal reflections as well. So we really hope that you're going to get a lot out of tonight's presentations, as I'm sure I will. So I'm now going to introduce our first speaker. A very important member of the collaborative, in fact, is our first speaker, Professor Helen Skouteris. She leads our research group at the collaborative. And if there are any researchers here tonight, please join us, please sign up and join us. Professor Skouteris is based here at Monash, and she's going to tell us a little bit about herself before she starts her presentation, which is called Coverage and Representation of Multicultural Populations in Healthcare Research in Australia, Time for Urgent Action. Please welcome Helen.
Thank you, Marina, and thank you, everybody. It's such an honour to be here with you tonight, and an absolute honour to be part of this Australian Multicultural Health Collaborative, which is a brilliant initiative. And you will hear more about that tonight. Thank you for all of you online as well. I know we can't see you, but we know you're there. So thank you very much. I will now share my screen. So give me a second to do that. So today I'm going to talk to you about multicultural content in Australian healthcare journals. As Marina said, my name is Helen Skouteris. I have a joint appointment with Monash University and Warwick University, actually in the UK, in health and social care improvement and implementation science. And I head up a health and social care unit in the School of Public Health and Preventive Medicine. This is me with my parents in Greece. So I am second generation born to migrants of Greece who came out in the early 60s. And my children there and husband, my children will still tell you they're Greek, even though they're third generation. And I have to always remind them that they're actually Australian, born to parents who were born in Australia. But, you know, that ethnicity is really, really, really strong. What I want you to notice is my parents' faces. And that's not because they're not happy people, but they hadn't been back to Greece for about 36 years. And they did go under very, very tragic circumstances. My cousin, my dad's brother's son, suicided. That was the first time they went back to their homeland. And you can just see, even in this photo with their daughter, how painful it was to return back after so many years. And this is the life of a migrant. So we know that more than half of Australia's residents, 51.5% to be precise, report being born overseas or having an overseas born parent. So we are definitely a multicultural country, and no one can tell us anything other than that. And you'll see there a very recent publication by colleagues here in Australia that outlines very clearly that access to health services amongst culturally and linguistically diverse populations in the Australian universal healthcare system is still extremely challenged. So this is a very recent publication, and it outlines very clearly that people from culturally and linguistically diverse backgrounds have multiple interacting social factors and diseases, low access to health services, and face challenges in the multi-level health and social systems in 2022. So sadly, this was also the case when Garrett and colleagues published their paper, a seminal paper, back in 2010. And they asked the question about representations and coverage of non-English speaking immigrants and multicultural issues in 3 major Australian healthcare publications. They wanted to know, are we reporting on the health of our multicultural Australians? And are we doing that in reputable, high-profile Australian medical and health journals? So the three journals they reviewed were the Medical Journal of Australia, you might know it as MJA, the Australian Health Review, and the Australian and New Zealand Journal of Public Health. They used 6 standard terms to search in databases. And you can see those words there: non-English speaking, ethnic, migrant, immigrant, refugee, and multicultural. And all publications in the journals that were yielded in the search were then analysed to exclude those articles which were duplicated or not relevant to the aim of their study. And then the articles were categorised according to article type, whether they were original research, policy article, and so forth, and the degree of coverage of multicultural content. The summary of that 2010 review revealed that in total, across those 3 journals, 4,146 articles were published over that 12-year period that first paper considered. A total of 90, or 2.2% of the total articles focused primarily on multicultural health issues. The range, volume, and overall quality of evidence that is required for equity in healthcare was extremely limited, 2.2%. And they concluded, Garrett et al. In their 2010 paper, concluded that whilst the MJA, the Australian Health Review, and the Australian and New Zealand Journal of Public Health research platforms could certainly not be called monocultural, they could quite reasonably be called limited and uneven. While there is some excellent quality research in respect of refugees, asylum seekers, and Vietnamese immigrants, there are other communities and health issues that are essentially invisible or underrepresented in research that was published in those journals. And that makes complete sense because there was only literally 90 out of 4,146. So as part of the Australian Multicultural Health Collaborative, there is a research and data working group, and we sought to extend the work of that initial paper that was published in 2010. And we have done so. And we have now shown, as you can see there, in the green line is the representation of papers, the percentage of papers for the Garrett paper. And you can then see in the blue line the percentage of papers for the systematic literature review, the review of papers that we have conducted to 2023. So again, you can see a vast number of papers have been published between 2008, which was the last year that Garrett and his colleagues considered in their 12-year span, and we considered as an extension from 2008 to 2023. So a 15-year period. In that 15-year period, you can see there that the MJA, the AHR, the ANZ JPH have published in total 7,280 papers. And in total, the number of papers, original articles that are focused specifically and with determination on multicultural health was 80. So that 80 is 1.1% of the total articles that focus primarily on multicultural health issues. There were a further 30 articles that had a major or moderate level of consideration of multicultural health issues, and 13 had a minor mention. So overall, even when considering, being really fair and trying to consider those that had some focus, but it wasn't specific and it wasn't the primary focus, overall 155 papers out of over 7,000 articles in the last 15 years, 2.1%. of all articles included some mention of multicultural health issues. So compared to the Garrett paper, the 2010 review, the original review, despite a greater number of publications between 2008 and January 2023, all indicators of inclusion of multicultural health content have decreased in number. So in response to the very simple question that we asked as a collaborative, we were really interested in our discussions. We had a couple of meetings and we were really interested about, there were many of us that already knew about this original Garrett paper, and Marina in particular cites it whenever she needs to for policy and advocacy. And so we asked the question, does coverage of multicultural health issues and issues pertaining to immigrants in major Australian healthcare journals reflect Australia's ethnic diversity and the disadvantages experienced by this population? We really wanted to know the answer to that question, literally 13 years after Garrett had first published their paper. And the answer, sadly and disturbingly, is no. So clear recommendations here. Without research and dissemination of findings on issues faced by immigrants in Australia, the disparities in access to equitable health and social care for this population it will continue. I shouldn't have even written likely. It will definitely continue. The social disadvantages faced by migrants and the challenges they face highlights that developing effective strategies to break down the silos in health and social care is imperative. We cannot ignore that any longer. However, without the literature, without the evidence base, without the equity in what we see for non-migrant and refugee populations and asylum seeker populations, without that literature, given that it's not available to healthcare professionals mirroring this priority, migrants in Australia are likely to face ongoing vulnerability. And again, I should have said will face ongoing vulnerability. So clearly there is an absolute need for the Australian Multicultural Health Collaborative to become the national peak body to represent this voice, what I'm telling you today, and much, much more that needs to be heard, not just by us here in this lecture theatre, those who are online, but literally everybody in Australia, every single person in every single sector, especially our policymakers, especially those in government who are making decisions, need to understand this is devastating. When we started this review, we did not expect this. And we sadly have to report that in Australia, the findings have gone backwards, and it's 2023. So that's the last slide. I will go back, actually. I went too far. But sorry to be the bearer of such bad news. It is something that we all need to take away from today. The seriousness of these findings cannot be ignored. And we need to, as a collective, we have a collaborative, but more so as a whole collective across the country, advocate for better health equity for those, especially those Australians and those living in Australia who need it most. So thank you very much, everyone.
Thank you, Helen. Well, that is a really devastating outcome from that study. As Helen said, that original study, I quote all the time. I know that 2.2% off by heart, and unfortunately now it's 1.1, it's halved. And it certainly explains, I guess, for those of us who work, in this sector, it explains why we can never find evidence, why we can never find those journal articles, because this is what we're up against, that, in these mainstream health journals, our populations aren't represented. So, yeah, I guess there's a lot of work for us to do in Australia and in the collaborative particularly. So, and I think we're going to be referencing your study for years to come. So now I would like to introduce Dr. Chris Lemoh, who was also a member of the collaborative. Chris is a medical doctor based here in Melbourne, and he's also going to tell us a little bit about himself rather than me introducing him with a bio. His presentation title is called Counterpoint. So please welcome Dr. Chris Lemoh.
Thanks very much, Marina, for that introduction, and thanks, Helen, for that great talk. Thank you to the Multicultural Health Collaborative for inviting me to speak, and just like to acknowledge the traditional owners of the land that we're meeting on and pay respects to elders past, present and emerging. That presentation of the lack of information, the lack of published scientific information about culturally diverse populations in Australia, which means the population of Australia, is unfortunately not surprising. Having done some research and also being in clinical practice as a doctor, this is what we're dealing with. For myself, I'm an infectious disease physician. I also work as a general physician. I'm in the Australian public hospitals for the last 20-something years. Needless to say, what I say tonight is my view, not that of any employers or other associated entities. So this is just my thoughts based on my practice, based on my research and conversations with the wonderful people that I've had the fortune to meet. I'm sort of engaged in clinical practice. Of course, I do teach as well, teach medical students and junior doctors, and also do occupy a leadership position in one of the hospitals in town. My research in the past has been a mixture of clinical research, also some epidemiology, some social epidemiology, and I've also been engaged in advocacy for migrants and asylum seekers and refugees, particularly around HIV, viral hepatitis and sexual health, but also more general health issues as well. Personally, although I'm Australian born, English speaking, Australian citizen, so in the census, I'm pretty vanilla, but those of you who are here can see that that's not necessarily the case. So my mother's white Anglo-Australian settler. Dad is from Sierra Leone in West Africa. And I was born here, but I did live in the UK and did my high school years in Sierra Leone as well, in that post-colonial setting. Sorry? Oh, I'm mute.
We can't see your slides in full. So, yeah, sorry. So that's my fault. So let's just stop sharing and share again. I need to become a technician. Yes. Okay. All right. That's better.
Thank you.
Okay. Sorry. Terrific. Thank you. Sorry, Chris, you'll have to go back and tell us again about your background.
So born in Australia and English speaking Australian citizen, but my father's Black African from Sierra Leone. My mum's white Australian. And I lived in Australia, but also in West Africa in post-colonial setting. And also lived for a little bit of time in the UK, in the metropole of the what is now the Commonwealth and what was formerly the British Empire. My interests are medicine, martial arts, and also looking at music and reading lots of different things. And it's interesting how many themes do echo amongst all of those different domains. When you have your interest peaked in one area, you see the echoes in other areas as well. And with a partner and a child, there are also very important priorities at home, and also some investment in making the future a bit better than the present. When we were taught certainly in medical school in the late 80s, scientific racism was just the air we breathed. And it wasn't until many years later that really even understood that as a concept. We were being told about racial characteristics, and all of the normal ranges for tests were sort of European by default. And we were exposed in social settings to the more sort of brutal interpersonal racism of the 1980s. But also it was, when multiculturalism in Australia was starting to become a more accepted or more popular and more populist kind of political language. But at the same time, although there were a lot of people from many different backgrounds in study groups and university, it was very clear who was normal and who was the other. Pretty much all my work has been in public hospitals in Australia, mainly in the city, but going to Alice Springs when I was a couple of years out in the sort of mid-90s was very much an eye-opener. So having lived in West Africa, I was quite struck by the deprivation and the marginalisation of Indigenous people in Alice Springs, But the other thing that struck me was how much energy and how much resistance there was and how much activity there was in changing that situation, which was very much a different picture to the sort of passive disappearance which we'd been taught in primary school in Australia. I specialised in infectious diseases and general medicine, and the perspective that gave me was looking at everything from the microscopic to the global, and really seeing the importance of zooming in and out between all of those different levels and seeing the relationships between, the global politics and, which, bacteria was going to infect somebody and which antibiotics would work against it. However, in clinical practice, racial stereotypes are just the norm. The papers that we read from scientific journals, usually from the US, uncritically reproduce sort of racial groups and ethnic groups, which make no rational sense if you stop to think about them, but most people don't. We did have a bit more consciousness of Australia's Indigenous history and colonisation as time went by, but in a very hierarchical and closed system like medicine and hospital medicine in particular, culture is very slow to change. And the Anglophone chauvinism, which was just the norm, continues despite the increasing ethnic diversity of the workforce. And so we'll have young doctors from Chinese or Vietnamese or Indian backgrounds without a second thought say, oh, this person couldn't take a history. I couldn't take a history from this person because they're not English speaking, or this person's cold. And from the other extreme, being completely colorblind and having no thought that someone's ethnic background or their cultural identity or even their life history would have any bearing on, the problems that they might have, the diseases which might need to be considered in their diagnosis. And so, if you tell me that, John's come in with a cough, I might think of a few different things, but then you tell me John's from India or from Vietnam, it might be a bit different than if John's from UK. And, you might not actually realize that until you get to the end of the bed. And people just don't really stop to think about that when they're talking about patients, which I think is quite interesting. It's probably better than overt racism, but it's still a problem. I was engaged in a lot of research over the years. Probably some of it took longer than it should, but plenty of time to think. Both using sort of statistical research as well as qualitative research. But one of the most important lessons I learned was the importance of community collaboration and being led by communities. Did some work with some really active people from African communities in Victoria, which again transformed my view of medicine and sort of started to make a crack into that edifice of, of what I'd been taught. And really bringing in the importance of the biological, the psychological and the social when you're looking at the complex issues around health. Started to learn about the social determinants of health and then more importantly, the political determinants of the social determinants of health. So this was in the years when, asylum seekers were starting to be vilified and there were a lot of quite obvious political implications, or social health implications of politics. Doing research in epidemiology, people always talk about populations. And again, one of the important distinctions to make was the difference between populations and communities. And it's very easy to label people and categorize them, which is again, a very kind of colonial way of dealing with people. But when someone's identification and their relationships don't match up with their color coding, you can get some serious either absences in the evidence, as we've heard today, or just mismatches. There was also a clear tension between individual health and caring for people as individuals and the public. I think that's been really starkly shown in the last couple of years. And also clinical medicine and the relationship between a clinical clinician and their patient or their client and the public. And I think COVID has done many things, but one of the things it's really done is show up the tension and the need to do both. With advocacy, community-led partnerships were really important. So this was mainly in the HIV space, so working with positive organisations, with organisations advocating for people injecting drugs, the sex workers, and gay and bisexual men, and other members of queer communities. And this was really a revelation to a standard hospital-trained doctor But it showed what can be done. And if you look at how public health is in Australia in the 21st century, so much of that is actually due to AIDS activists in the 80s and 90s. The relationship between community researchers, government and clinicians has been defined by that, although it only gets talked about on rare occasions. Intersectionality is something that people are talking about now in so many words, but it's a lived experience for many people. And one of the really important shifts in the language that we've been able to use is that move away from individual psychological identity and identity politics towards more systematic and structural perspectives on difference and structural racism, rather than talking about bigotry and prejudice. Being a member of a diaspora, having a transnational perspective is something that's really important. Again, nationalism is something which seems to be around forever, but it's only been around for a few hundred years. And given the proportion of people from migrant backgrounds in Australia, most people have got family overseas. Most people have got social networks that cross national boundaries. And of course, as we know all too well, microbes don't respect national boundaries. You can't give a virus a passport. And having that transnational perspective and thinking of populations and communities that cross those jurisdictional boundaries is something that public health and global health is starting to grapple with, but clinical medicine is still way behind. So having somebody turn up in a hospital who hasn't got a health insurance suddenly creates a whole lot of dilemmas about how much care they should get and who's going to pay for it when they can't because they don't have an insurance, which is just a really violation of people's human rights. But unfortunately, it's a very common occurrence, particularly in the sort of suburban hospitals of Australia, where people from migrant backgrounds and their visiting friends and relatives are frequent patients of those health services. Another interesting quirk about Australia is the reliance on charity for providing services, which you would think would be a human right. We had some really interesting conversations recently in the collaborative about health justice. So we do talk about equity, but I think health justice is a better term, because a lot of this is unjust, and relying on charity for something that people should get and are deprived of for unfair reasons is not just. The context of this, the war on terror was happening through the 2000s, and that created a whole lot of really uncomfortable developments in surveillance, categorization of people who were citizens or residents of a country, but were suddenly not real citizens and not real residents. And if you said the wrong thing on a significant day, which anniversary just passed a couple of days ago, you got hounded out of the country. The war on drugs is another racial war. So that's something that in America particularly disproportionately affects Black and Hispanic communities. And in many parts of the world, that moral outrage around drugs has really hampered the provision of healthcare and social services to people who have an addiction. In Australia, that is still the case. I think people who inject drugs are probably the second most stigmatized group of people in the healthcare system. And of course, offshore detention of asylum seekers was another blatant example of the political impact, the impact of politics on healthcare. In a less spectacular fashion, the sort of financialization and the micromanagement and micro-budget holding of health services, both in primary care and the hospitals, has led to a real paralysis in improving the care for people when everybody is counting the pennies. And even if overall it costs the health system more to do that micro-budgeting, we still do it because the temptation is to preserve yourself and your office at the price of someone else's healthcare. And this comes into out-of-pocket costs for medications and tests, both in the hospital and in primary care, although our two-tier government system and the two-tier funding is another example of how that disadvantages people. And this disproportionately affects people from migrant backgrounds, both those who are permanent residents, but more particularly those who are temporary residents, like international students, temporary workers, who have much less incentive to seek healthcare and therefore more likely to be diagnosed late with conditions which are very treatable. And so you end up with people losing limbs from diabetes, people having strokes from hypertension and so on. And I think one of the really pernicious influences has been the commodification of everything. So everything can be sold, everything can be bought. Healthcare as a commodity, aged care as a commodity has had some really unfortunate effects on healthcare. And again, it's disproportionately fallen on people of colour, people from migrant backgrounds, as well as Indigenous people. In teaching is another part of what I do, and that's been quite interesting. The internalisation of that, I guess, colonial mentality, and that it's also a patriarchal mentality, was very deep. And it wasn't until learning how to teach that I was able to see how damaging some of those attitudes and, you know, the instructional sarcasm and the bullying and the belittling of people in the name of education, which again goes back to a peculiar cultural formation, which has got a worldwide influence from Western Europe. And even words like professionalism and workplace culture are sort of touted as universals, but they're actually very ethnically specific. And that's something that it's only really become a very recent part of my understanding. We have a lot of structural discrimination in healthcare, particularly when it comes to people who've got qualifications overseas, whose English is not their first language, it might be their third or fourth. This leads to people spending a lot of time trying to get their qualifications recognised in Australia when they've got quite valuable experience in other health contexts, and often quite a lot of cultural understanding of the patients we see in the hospitals, but that's not officially recognised most of the time, and it's a real waste. We see marginalised patients being discriminated against, so people injecting drugs, people with mental illness, refugees and asylum seekers, and also people from culturally diverse backgrounds, as I said before, where language is seen as a barrier or a problem, and the people are seen as a problem rather than having needs which we are not adequate to meet. And even science, and we've talked about the scientific evidence and the practice of it, both in what's funded, how the questions are formulated, what methods we use to investigate them, how we interpret the results and how we publicise the results. All of that is culturally influenced. And it's driven partly by the money in the capitalist system, where journals are businesses and need to make money. We have a very colonial structure still, where groups of people are studied, labelled, categorised, and then have policies applied to them without consultation. And it's still a very imperial system. When you look at the health workforce and again, the cultural background of the people who have the lowest pay, who have the most unpleasant jobs, and then you sort of raise the altitude to the sort of managerial class, you see a very obvious distinction in ethnic background. And again, we are barely able to say racism when we're talking about health policy or research, and white supremacy is another one that is very uncomfortable to say, but in fact, that's what it is. When you've got so many different people from different backgrounds, all experiencing the same marginalisation, the same discrimination in their own particular manner, whether they're Indigenous or from cultural minorities or from stigmatised groups like people who inject drugs, it's still the same group of people who come up on the better side of that division. Going into a more managerial sort of role, learning the difficulties of managing relationships and communication, actually creating culture in the material constraints which we have in a sort of resource poor setting. A lot of the time public hospital medicine seems to be a post-colonial setting. We're sort of managing challenges with growing demands and decreasing resources a lot of the time. And people find it very hard to change their thinking and their practice when they're tired and stressed and overworked. And so a lot of these stereotypes and these biases that are baked into us at a very young age come out in how people talk to patients and clients, how people actually respond to challenges of communication or conflict or tension in the healthcare setting. And that tends to end up with some very unfortunate experiences for the people who have the least social capital and social resources to deal with them. And one of the, I guess one of the themes that sort of come through more recently is what is culture? I mean, we do talk about ethnic culture a lot, but culture is pretty much the meaning that we share and the stories that we tell each other about ourselves. It's a human trait. It's almost like coral. It's our biofilm in my infectious diseases sort of mindset. It's what we produce in order to live. And that's not a fixed. It's often talked about as if, you know, tradition and identity are these fixed, immovable parts of our social landscape. But of course, they're constantly being reproduced and recreated every day by the way we talk to each other and gather together in the stories that we tell. So finding out what to do with all of this, changing understanding, which is ongoing. Every conversation is another opportunity to learn. But one of the things I've taken really to heart is to think about who, not what. So rather than label people as objects, think about who they are, ask them rather than telling them. And treating people with respect and recognizing their unique and valuable perspective, both as individuals and collective. Again, sounds easy to say, it's much more difficult to actually do, particularly in the context that we're in and the relationships that we have. And the most important thing in collaboration is to actually find out what people are trying to achieve. Why are they doing what they do, and try and align that. And I think one of the important parts of this collaborative is to try and create, I guess, momentum or impetus at a policy level, at a national level, to do that systematically, rather than each of us having to learn this lesson individually over the course of a couple of decades. It just takes too long. Every time we make a decision, we draw a boundary between what is and what is not, what we're going to do and what we're not going to do. And the trouble with that sometimes is we get very inflexible and we just accumulate these distinctions until you finally get someone who has been cut out of every single decision there is, whether it's what category they go in the census or what category they go in the registration form at the clinic, and there's just no place for them. We need to sort of remember that what we do, we can undo, and that there are people for whom there is no label. And maybe we should ask them what they want to be called and what their priorities are, rather than trying to shove them into a box or just leaving them out altogether. Every time we make a decision about how we're going to deal with information, we leave things out. There are always gaps in every set of services, and we need to see what's in those gaps. When we're speaking, we need to think about who's not talking and listen to what those silences mean, and then flip it to see what's on the other side. How does it look if you're in a clinic? How does it look as a patient? How does it look as a relative? How does it look as the cleaner? Because you'll see something that you wouldn't see if you just walk in there in a position of power. So I mean, I think we do die in the gaps. One of my martial arts teachers kept, this is one of his favorite sayings, and the gap between seeing and looking, the gap between hearing and listening, the gap between feeling and caring, and the gap between knowing and doing. And there's that gap between contact and recognition. And I think this gap between me and you will be the death of us. And that's, I think, speaks to what Helen was saying before. Thank you.
Thank you so much, Chris. I always look forward to your presentations. I think you have an amazing way of bringing the personal to the professional to the political analysis. So thank you very much. Just a reminder that after our keynote speaker, who's coming on next, we will be having a Q&A session. So please, for the people watching online, put your questions in the Q&A box. And people here tonight, you'll have an opportunity to ask questions as well. So now it's my great pleasure to introduce our keynote speaker for this evening. I've recently read some of his work in The Lancet and became really excited and just emailed him and said, would you join us for this event? And he said yes. So we all actually, we were all really blown away by his generosity. So I'd like to now introduce our keynote, Professor Delan Devakumar from University College London. Professor Devakumar is a professor of global child health and co-director of the Centre for the Health of Women, Children and Adolescents in the UCL Institute of Global Health. He is an honorary consultant in public health. He has a distinguished career, having worked internationally as a paediatrician and researcher in New Zealand, Pakistan, South Sudan and Myanmar. He was a commissioner and steering group member of the UCL Landsat Commission on Migration and Health. And the most recent work that I just mentioned, he was a lead for the Landsat series on racism, xenophobia, discrimination and health. Tonight, his presentation is called The Health Consequences of Racism and Xenophobia Towards Migrants. Please welcome Professor Delan Devakumar, who's just come online. Welcome, Delan.
Much. Thank you, Marina. Let me just try to share my slides. Great. Thank you very much. Firstly, I want to thank you for asking me to speak today. It's really an honor to speak to you. And it's really great to hear the last presentations by Helen and Chris. My talk is going to be about the global picture, about what happens across the world with a focus on the UK where I live, but hearing about specifically what happens in Australia, about the conditions that you have there is really important for me to learn about. So thank you very much. And thank you, Marina, for inviting me. It's great to speak to you. I wish I could have been there, actually. That would have been even better. So my talk, I'm going to give a broad overview on migration and racism and xenophobia, with a focus on these two publications, as Marina mentioned, the UCL Lancet Commission on Migration and Health, which was published in December 2018, and then the Lancet series on migration, racism, xenophobia, and discrimination, which was published in December last year. So my talk, I'm going to start talking about migration generally and then switch to the work on racism, and hopefully there'll be a synergy between the two. So try to give a global picture of what's happening around the world, and then in occasions go a little bit deeper in certain situations. So first, just to give some context about migration, and I think it's important to start by saying that migration is a reality. You mentioned that the majority of people in Australia are migrants or I think second-generation migrants. So migration is normal. Humans have always migrated, moved across Africa and out of Africa, and then across the rest of the world. And currently there's 281 million international migrants, which make up 3.6% of the world's population. And there's about 3 times as many, around estimated at 740 million internal migrants, so people who move within the boundaries of a country, which together they make up around 1 in 8 people in the world. It's around 1 billion people. So migration and migrants are very common. But also, correspondingly, if we think about the 3.6% of the world's population, in places like the UK and in Europe, there's talk about the migration crisis, that hordes of people, in inverted commas, who are coming over to here. But really, this percentage is actually quite small in terms of a global percentage. But what has changed recently is that those in positions of power have sought to restrict and publicly condemn migrants and migration. And there's increasing discrimination towards migrants, which leads to poorer health outcomes, particularly mental health and social well-being, for those people who are living in these states of persistent unpredictability, who go through treacherous journeys to reach their destination countries. And we've seen this across the world in some of the biggest, most powerful countries in the world. President Donald Trump talking about Mexican migrants bringing infectious disease to the US. Jair Bolsonaro in Brazil, the previous president, who talked about people coming to Brazil, people from Haiti, from Syria as being the scum of the world coming to Brazil, this demonization of migrants. And then in the UK, the overt government policy, the hostile environment towards migrants that started under the Theresa May government. And then, of course, Brexit, with this sort of undertones of xenophobia, Nigel Farage talking about being a breaking point in front of this poster of people. So this idea, this populist tendencies, this demonization of migrants leads to poor health, not only for the migrants themselves, but also for the whole population. So within the Lancet Commission, we sought to think about some of these myths and try to challenge some of these myths. And I'm going to mention a couple of them today. One of the myths was on migrants being a burden to societies, to the services in the countries that they go to. And really what we see is that the opposite is true, that migrants tend to be a gain for the population, the destination population. And countries that have a net migrant intake, high-income countries in particular. So if we look at particularly adult migrants, a 1% increase in migrants leads to a 2% increase in gross domestic product. Migrants come in and help fill jobs, grow the economy, increase services, and these are a whole range of people from low-skilled to high-skilled migrants, all contributing to the economy, increasing the income of the population. If we look at the National Health Service in the UK, for example, we see just over a third of medical doctors gain their qualification in another country. These migrants are bringing skills, looking after the population in the country, and the NHS, where I worked, would collapse without foreign trained health professionals. The next myth, which was espoused by President Trump, was about migrants being disease carriers that pose a risk to the resident population. And really, this isn't borne out by the evidence. Migrants tend to be healthier on the whole, and migrants are a selected population who are able to move. And this work, led by Professor Rob Aldrich, which was linked to the Commission, looked at the mortality amongst migrants in a large study with over 15 million migrants. This was a meta-analysis of studies. Found that migrants actually have a lower mortality risk, standardized mortality ratio, compared to the local population, about 30% lower. And that's true for males and females, and refugees, in particular asylum seekers, they found no difference. So what we find that is that migrants tend to be healthier on the whole, but importantly, the migration journey, the reasons that cause the migration in the first place, and then the destination country as well, can lead to migrants becoming unwell. So actually, migrants themselves may be at a higher risk of illness, but their risk of passing it on to the host population is very small, negligible. And this is really about the conditions that migrants move and live in, and the policies around migration. So this is from the International Organization for Migration, that describe these conditions around shelter, the increased risk of injuries, illnesses, gastrointestinal illnesses, complications from lack of treatment and interruption of care that migrants face through their journey. And in the Commission, we thought a lot about the migrant journeys and came up with this figure on the left. The idea of a person moving from A to B on a flight is a form of migration, but also there are many other forms of migration, and some that have interception phases and who are sent back, that longer term migration where people may be stuck within this phase of migration for years, for decades, and sometimes forced to return home. So migration in and of itself can be a very prolonged process. And one group I particularly want to kind of highlight is unaccompanied minors. And this is some work led by my PhD student, Dr. Susanna Corona-Maioli. Unaccompanied minors are children or adolescents who are separated from their parents or other relatives. And this group of children, young people, face particular risks because of the lack of protection, and sometimes laws that actively demonize young migrants. We see particularly young boys are demonized within the press in the UK. And these young people face physical conditions, nutritional deficiencies, dental caries, increased risks of infection, links to low vaccination coverage, and then forms of violence across this journey of migration. And this often results in mental health conditions, post-traumatic stress disorder, depression, anxiety, and a whole host of other forms of mental ill health. And looking at this, we looked at the different phases of migration around the reasons that people are forced to migrate, conflicts, wars, the transit phases that they go through, and then arrival. And importantly, within this, the forms of discrimination that these young people face. So thinking a little more about how health systems can be set up to support or deny access to migrants. We're increasingly seeing that entry for migrants on the grounds of public health protection is not supported by evidence. So migrants may be at increased risk of getting an infectious disease, but that's really about the conditions that they live in, the preventive reasons, for example, vaccinations, the physical environment that someone lives in that may increase their risk of catching an infection. And what we're seeing are these structural system barriers that may prevent access to healthcare. The increased stress, this fear of deportation, the linkage between healthcare and border services in immigration controls. We see that states are treating migrants as criminals when migration is not an illegal activity. We see restrictions put on people. We see the right to access being denied for people. And really, this is a human right, as was mentioned in the last talk. The circumstances around migration may force people to move. We see that actually designing a health system that improves and integrates migrant populations will be of benefit both to the migrants themselves, but also to the wider population. One example of this is some work we did looking at undocumented migrant children in the UK. This was led by Dr. Neil Russell. And undocumented migrants are people who lack the documentation that provide a regular migration status. So these are people who are often under the radar, who are not picked up by services. And what we have within the UK, within our hostile environment towards migrants, there's a charging system that's been introduced. So the National Health Service is free at the point of access for all people, but the introduction was a mandatory upfront charging for migrants for secondary care. And this extends to children, which it often doesn't in other countries. And this charge is above the usual NHS tariff. And if debts are not paid, those people can be referred to the Home Office. So what does this mean? Well, what actually happens? Well, we see that parents are, assume that the healthcare that they receive, that this link with the Home Office, they might be worried about going to see a health professional. They might delay the treatment. They might delay taking their child. And also, it's a very hard system to understand, even as health professionals. Speaking to colleagues of mine, it's not a system that most health professionals really understand. Who is eligible, who is not, what the exemptions are, who will be referred, who won't. We see within healthcare that antenatal care is charged, for example, and the average cost of antenatal care is around £6,000 per delivery, with some costs going much higher. So what this results in is poorer care for children, poorer access for children. These barriers that are put up mean that these children won't attend or will attend later. And there are safeguarding issues, and this certain groups such as trafficked children are exempt from charging, but it's often difficult to know who is a trafficked child and who isn't. So those are barriers where everyone is treated the same initially. And this, I should have mentioned that there are around 120,000 undocumented migrant children within the UK. So this is a large population of children. And actually, around half of those children were born in the UK. and are undocumented because of the status of their parents. So the last thing I want to talk about briefly is on detention. And this is, again, increasingly used where populations are met with these punitive border policies that lock up people. And these detention policies are a clear violation of international law, that these are not permitted within international law usually. But we see the US, for example, having this zero tolerance policy where migrants may be arrested, children may be separated from their parents. A systematic review within our commission report found that detention was associated with negative health outcomes, especially mental health, and that, I suppose, stands to reason. And then this kind of offshoring of detention, and I'll be keen to learn from you around the situation in Nauru for migrants trying to come to Australia. The UK has recently instituted a policy to send asylum-seeking people to Rwanda, and it's currently under legal challenge, but this is a policy under the current Conservative government. So the recommendations that we set out within the Migration Commission was that we should improve leadership, we should set up a global migration observatory, we should rebalance policy making, giving greater prominence to health, we should think about the macroeconomic forces that lead to migration, we should think about universal and equitable access to migrants. But I just want to highlight the last one, and this was that racism and prejudice should be confronted with a zero tolerance approach. Public leaders and elected officials have a political, social, and legal responsibility to oppose xenophobia and racism that fuels prejudice and exclusion of migrant populations. So this was published in 2018, and the Migration Commission was linked to the UN Global Compacts for migrants and refugees, asylum seekers. Sorry, linked time-wise, not formally linked. And that was in some ways a kind of hopeful time for trying to push the agenda towards improving the health of migrants. But this idea of racism and xenophobia, and this seemed very core to the migration work, and this is something I worked on more subsequently. So in 2019, started this work. And it was really with a few aims to provide increased recognition for these issues, racism, xenophobia, discrimination, as key determinants of health. And I say that as someone formerly clinician, public health doctor, now works in research. Even for someone like me, I suppose when I did clinical consultations, I didn't ask about issues of racism. I didn't ask about those issues that people might be facing. I then wanted to think about it as a global health issue. So there are similar things happening all over the world. There are similar drivers and health consequences that may be based on someone's caste or ethnicity, on their religion, on all these criteria mentioned here. And then to focus on the structural causes. People think about interpersonal forms of violence, verbal abuse, physical abuse, but usually the underlying structures that lead to those manifestations are not considered. So I started this work in 2019 when the general discourse around racism was pretty minimal, as was discussed in previous presentations today. But then in 2020, lots of things changed. And one, of course, was the COVID-19 pandemic. And we saw active acts of racism, targeting of East Asian people, for example. And then, as I'll come back to, differential mortality, morbidity amongst ethnic groups. And then, of course, the murder of George Floyd and the Black Lives Matter movements that followed, and the increased discourse around racism, around structural forms that are leading to these deeply rooted systems of oppression that results in the death of innocent people. So what is racism? Well, racism can be defined as an organized system that affords power and privilege according to an established hierarchy of these racial categories. And that's designed to protect rights, power, livelihoods of those who are at the top of this hierarchy. Xenophobia is a very similar concept, but it's about those who are considered to be foreigners, so particularly pertinent to migrants. And then discrimination of these differential treatments or outcomes that are unfavorable towards groups or individuals. And I should say that there's a lot of overlap between racism and xenophobia, and there are a variety of definitions that are similar to this. But somebody may be discriminated against because of where they've come from, because of their religion, their ethnicity, their race. All of these different factors kind of blur together and overlap. So for racism to exist, we need racial categories. And this goes back to the 1700s, to the original categories by Blumenbach and Linnaeus. Johann Friedrich Blumenbach described these racial categories really by color, and those categories persist till today. Linnaeus went one step further to talk about characteristics that people have, to talk about Americanus people as being merry, Asiaticus as being melancholy, Africanus being crafty, indolent. And of course, European people are sanguine, muscular, inventive. They place themselves, their own groups, at the top of this hierarchy. So I think I should just stop to stress that these are social categories. These are designed by people who were categorizing humans and other animal populations. These are not biological categories, and that's really important to stress, that there are no differences. Humans are genetically one of the most similar forms, similar animals out of the whole animal kingdom. So these races and these racial differences are social categories, but racism is very real and very important, and we see differential outcomes amongst different populations. Within our work, we wanted to look back at the history, and I think it's important just to highlight this one example. So eugenics, and I speak as a professor of global child health from UCL, University College London, that was the scientific home of the eugenics movement. And under Francis Galton, Carl Pearson as well, provided some of the scientific basis for eugenics. Galton described eugenics as dealing with what is more valuable than money or lands, namely the heritage of high character, capable brains, fine physique and vigor. It aims at the evolution and preservation of higher races of men, of course, men who looked like Francis Galton. And this idea was to divide people into different groups, people who are worthy to give life and people who aren't. And these concepts and these ideas have persisted onwards. And the recent inquiry into the history of eugenics at UCL talked about how this is still implicated in compulsory sterilization, legislation on mental deficiencies, in inverted commas, immigration laws, racist policies, the notion of natural intelligence, normalization of segregation by race, ability, class. We see this still play out in policies and actions that happen today. The idea of forced sterilizations of Black women in the US, the Mississippi appendectomy, where women received hysterectomies. And this continued until the second half of the 20th century. So within living memory for many people. So within our work, we sought to look at the health consequences across a range of different levels. We focused on individual people, looking at behavioral, psychological, physiological consequences of racism. And this is previous work led by Professor Ian Paradies from Deakin University in Australia, who looked at the effects of racism on health outcomes. A review of 333 articles, mostly from the United States, 271, about 80% from the United States, found that there was an association between racism and poor mental health, including depression, anxiety, psychological stress, which was stronger amongst certain groups, Asian Americans, Latino Americans. and an association with general physical health as well. It's, again, significantly stronger for Latino people. We then summarize this whole huge body of evidence from across the world. And this, I guess this slide isn't really to read, but just to say that at every life stage, we see health consequences of racism, different forms of discrimination, both from an interpersonal perspective to the kind of structural. And this can be passed on. So I work on child health. We see how racism can affect children themselves, but also how this can lead to long-term consequences when they become adults later in life. This idea of hormonal overregulation, toxic stress or allostatic load, this idea of weathering where your hormones and neuroendocrine system go into become hyperactive to a certain extent, which leads to increased risk of non-communicable diseases. And this can also be passed on to the next generation. So we have this intergenerational effect of how racism, xenophobia, discrimination can work. And this was shown very vividly in the COVID-19 pandemic. And this is data from the Office for National Statistics in the UK. They looked at mortality differences amongst ethnic groups. And they found that Bangladeshi women were at 4 times risk of dying from COVID-19 compared to white British women. And Bangladeshi men at 5 times increased risk of dying. And just to stress from before that, these are races, ethnicities, social categories. There's no biological difference between people. So why does this happen? Well, this category BAME, Black, Asian, Minority, Ethnic, is a way people are often described in the UK from minority ethnic groups. So these ethnic minority groups are more likely to get infected from SARS-CoV-2. People in Pakistani, Bangladeshi groups are more likely to work in frontline service industry. Black populations more likely to work within health and social care. And they're more likely to live in accommodation, which increases the transmission of SARS-CoV-2 from one person to another. And then they're more likely to get a serious form of the infection. So more likely to have these barriers to accessing the health service that I'll come back to, more likely to have underlying non-communicable diseases that increase your risk of mortality. So all these things result in this far higher risk of dying from the COVID pandemic. So what we found is that there were very unequal consequences. We then looked at how this individual lives within a society and within the communities. And these communities can be supportive, can help protect against the effects of racism. And these communities can also be oppressive, that can victimize and persecute people. Then what we sought to do in building this model was to situate those people and communities within the spaces and world that they live in. And we see these different environmental consequences for people, that certain people are exposed to much higher levels of environmental toxins, to environmental degradation. We see indigenous populations being exposed to mining and the consequences of mining, for example. Within the UK, within London, we see high levels of air pollution affecting minoritized communities much more than other communities. And that what we wanted to do was to really get to the core of what this issue was. So in this, we projected this onto a model of the world. So think about how structural discrimination, separation, and hierarchical power can lead to the consequences that people face. So this idea of structural discrimination, in all of these systems, be it for migration, for religious minority groups, for all the different categories, indigenous people, for example, what we see is that people separate themselves from other people. And importantly, apply a hierarchy where certain groups are considered to be better than other groups. And people at the top have access to services, to opportunities that other people don't have. and this can perpetuate down generations. And we see this embedded into laws and governance, the apartheid system, for example, within South Africa, the Jim Crow laws in the US that divided populations according to their race. And we see this through the history of colonization. So classically, Northern European countries moved across the world and took over lands and divided up populations. And so sometimes those divisions were arbitrary, borders were created where borders didn't exist before. And this idea of the nation state, which largely developed after the last world wars, these are relatively new concepts. And even this idea of migrants moving across borders, it's a relatively new concept for humans, that these categories of people, these borders were created, and now we are regarding people who move across these borders as having lower rights, lower standing, and being illegal. So then we wanted to look at how these structural forms of discrimination lead to the health outcomes we see in individuals. And these are largely perpetuated through the institutions, to the systems in which people exist, and with a particular focus on the health system. So we describe the many different ways in which racism, structural forms and individual interpersonal forms of racism can affect individuals. And these were described in some detail by Chris in the previous presentation. So we think about forms of acceptability, accessibility, as I mentioned, these financial barriers that may be created, active forms of discrimination that are experienced by health workers, bullying, unequal progression through the system in terms of promotions. But it's important to say that while some of this may be done on purpose, there might be people who are actively discriminating against their patients, for example. A lot of these systems are just the way that the health system is set up. It isn't that somebody is trying to exclude a certain population, but because they may not have appropriate language translations, for example, that might exclude people who, in the case of the UK, whose first language isn't English. There might be barriers in terms of understanding or transport or reaching populations for vaccinations, for example. There might be understandable apprehension about vaccinations based on what's happened to the history of a population. So some of these barriers are set up and are just the way that the system is set up. Some of them are done on purpose, the hostile environment to discourage migrants from coming to the UK. But all of these can be worked on and changed and fixed to reduce the barriers for populations. And then finally, we provided this ring around the model to think about the life course and how at different stages, different people can be affected and how that can lead to consequences later in life. So in summary, this is the model that we created. And what we try to do is to flip the usual social ecological model to center the structural powers that lie underneath, that lead to the health consequences that we see. And then thinking about the other intersecting forms of oppression, which I'll come back to in a moment. So our third paper in the series looked at intersectionality, and this again was mentioned in previous presentations. Someone's identity is made up of many different aspects in terms of their race, their class, their sexuality, for example. And these all have particular hierarchies that can be at play, and unique, and each individual can experience unique forms of discrimination that can build upon each other. So we produced a number of case studies, including one from Australia, looking at different forms of discrimination around the world, and then trying to look at some of the commonalities between forms of discrimination. And what we found that there was a lot of similarities based on history and coloniality, even though the particular histories are very different. there were similarities across populations. This idea of separation and hierarchy that I mentioned before, this institutionalization, and certainly this happened in Australia, embedding racist systems into laws and health systems. The idea of visibility of Muslim populations, for example, being visibly different to other populations and experiencing racism. And then violence, and these are direct physical forms of violence, but also structural forms of violence. And then we try to look at what we can do. So we summarize different interventions across the layers of our conceptual model, from the individual to the structural. And what we see is that there are a number of individual forms of interventions. These are most common. Training, for example, for health workers. But usually these kinds of interventions were relatively short in nature, in duration, and the follow-up was relatively short. And often these types of interventions didn't work very well. What we think are probably the more effective interventions are the ones that go into the core of the problem. So tackling the structural ways in which systems can be set up, the laws that determine who gets access to healthcare and who doesn't. But I think in summary, these actions have to be multisectoral, have to be at all of these levels, from the individual through the health systems, through the kind of laws that govern a society. And I want to return to those structural forms, going back to a similar slide I showed at the start of this presentation. What we see is that people in positions of power are demonizing groups, demonizing migrants, demonizing people from particular races or ethnicities. And these are some of the most powerful people in the world, mostly men, actually. And we see this increasing populism going on, and this politics of blame and scapegoating. And this is happening here in the UK, this scapegoating of migrants who are coming over here, taking our resources, when actually there are much more deep-seated problems in countries that are not and migrants are not to blame for those. So finally, we call for 6 actions: decolonization, justice, genuine diversity and inclusion, taking an intersectional approach, anti-racist, specifically anti-racist actions, and a human rights-based approach. Each one of these is difficult to do, and each one of these has to be done at every level of the conceptual model I described before. And I suppose my question to everyone listening is, how can we do this? How can we actually produce a just health system? How can we take anti-racist action? How can we bring human rights into the clinical consultations that we might have? So I guess I would leave that for each person to think about how, within their own roles and work that they do, they might introduce some of these principles and take these forward. So in summary, categories such as race are biologically arbitrary. They're social categories, but the discrimination that minoritized people is very real, and that there are similar forms of systems of oppression with structural causes for many populations around the world. Importantly, issues such as migration, racism should be urgently treated as a core determinant of health and a priority within the century. And that the health community, including myself and I imagine many people watching this, have a responsibility to challenge and address these issues. It's part of our job to challenge these issues. And the last couple of minutes, if I can, I just wanted to play a short animation. I think a lot of what I've described, a lot of the work I do can be quite abstract, thinking about these structural forms of discrimination, thinking about it in conceptual ways. But racism is very real, and it means something to each person. And I think many of us have our own histories and reasons for doing it. And I just want to play this short animation where we collected audio clips from people around the world, and in each one of these, they describe what racism means to them.
El racismo para mí significa definir a otro como distinto y diferente a mí, de una manera tal que vale menos como persona. Por ejemplo, en Chile, donde yo vivo, crecí en una familia donde el tener color de piel blanco, ojos claros o color de cabello claro tenía mayor valía, y yo, siendo morena, sentí desde muy pequeña que yo entonces era menos bonita, o lo que decía o pensaba importaba menos. En el espacio profesional también he sentido experiencias de ser definida como menor valía por ser latina en Europa, lo que hace que uno viva la vida desde un lugar de más miedo, de mayor inseguridad sobre lo que piensa, hace o dice.
Racism to me is the beauty standard that we have in Samoa. If you look more indigenous or local, people will treat you in a way that is less than they would treat a foreigner.
My first awareness of racism was as a young brown child visiting the UK. It was to feel judged or watched every time I went into a shop or boarded a bus. It was to know implicitly that I was considered to be a different category of person than the members of a more powerful majority. It was to feel that I had to be an exemplary representative of my minority group who was deserving of acceptance, and to know that I always had to be alert to my precarious position. When I returned to live in Sri Lanka, my situation was completely reversed. I was privileged to be a member of the majority, and it was my neighbors, friends, and colleagues from minority groups who lived with the very real possibility of violence that could threaten their homes and lives.
I recognize racism in our school systems, but in the form of colonialism. As a Ugandan citizen, we were colonized by the British, which means that we had to adopt the British education system. However, years after we have gotten our independence, we are still, to a larger extent, being taught with the same education structure, which to me feels just not right. To a larger extent, the education that most Africans are getting is still colonized, so it makes it very unrelatable to young people.
Racismo é que é errado a gente falar mal da pessoa só pelo jeito que ela é. É muito errado. Então eu ia falar para a professora quem tá fazendo racismo, para ela conversar. E é isso.
So, thank you very much. That's the end of my presentation. If I can just direct you to our website, raceandhealth.org, where we have the academic resources that I mentioned through this presentation, but also a range of other things, podcasts, webinars. We have a newsletter you can sign up to if you're interested in this, and also to the Lancet Migration website, where you can read more about issues around migration and health. Thank you very much.
Thank you so much for that amazing presentation, Delan. There is so much to say after that presentation, but we're going to go to Q&A, and then we might wrap it up at the end. If you could stay for your Q&A, that would be fantastic. So Helen, do you want to come up here and moderate the Q&A? So we've got lots of questions online. We might go to some of those first, and then we'll go maybe to the auditorium.
Thank you from me too, Delan. That was a fascinating talk, and I could have listened for hours and hours, even though it's been a very long day and it's going into the evening today. So thank you very, very much. There are a couple of questions for me, so I'll answer those very quickly. And there was questions around what are some of the existing barriers to including culturally and linguistically diverse people in research. And one of the most highly cited reasons for people not including people from multicultural backgrounds, and especially those from non-English speaking backgrounds, is funding. They will just tell you that they don't have enough funding to be able to employ interpreters or bilingual community workers. That's one of the biggest issues that we face and that our governments need to address, because it is a really huge barrier. The paper that the results that I presented are not published yet. They will be published, and as soon as they are, we will disseminate them. And someone asked if they can get a copy of the slides. This presentation has been recorded, so you'll get a link to the recording, but the slides will not be disseminated. And one of the questions was, given the paucity of literature, what advice do you have for early career researchers starting to develop a program of research in health equity for culturally and linguistically diverse populations? My advice would be, do it. I think we have to just roll our sleeves up and say, we have to do this. And we need to, if government is not producing the funding, we need to link with other organisations. We need to consider how we can listen to the community needs. And as researchers, the one thing that I will highlight for early career researchers listening is that we need to be in service of our communities. We should not be leading research. We should be listening to and understanding what those issues are that our communities face and serving them with the research methodologies that are appropriate so that they can literally amass the evidence that they need. And so as an early career researcher, if you can really change the narrative of the work that you're doing and really understand that what you can offer is gold in terms of research skills and methodologies and an understanding of design, but that we are, as researchers, literally providing that service and enabling the consumer, the community, those with lived experience to voice, to be heard, and for us to be shaping the evidence that will be appropriate for them. So if we can start to do that, we will see a difference. Okay, so there is also a question here. I'll just read this out because it's quite a long, I think this one might be for you, Chris. Equity might not be the right word for my the question that this person is asking. Access and availability are a big issue, but one other aspect that is neglected is in the actual clinical provision of medical care. Many medical issues can be treated with the same medications for all, regardless of ethnic origin. However, there is a lot of evidence that the first line treatments for some conditions vary from one ethnic group to another, but this is never taught to medical students, nor is it shared, highlighted in medical guidelines. Simple examples are hypertensive medications. So Australia being a multicultural country, which has resulted in multiple ethnic groups, how can we make medical care equitable to all, ensuring everyone gets the right, best care? Sorry, it was very long, but you get it, Chris? Yep.
I get it. There's a lot in there.
That's right.
So ethnicity is pretty unequivocally a social category. Race is very equivocally social. Race is a really plastic kind of category, but basically it's inherited difference is how I think of it. And it can be whatever you label, if it's passed down, it can be treated as a race. And unfortunately, its intrinsic character is what makes people think that there are differences in the biochemistry or the physiology between people who've got different coloured skin or have different social categories. And the thing about research, and I'm sure that Delan can speak to this more than I can, it depends on how you ask the question as to what answer you get. And if you ask the question, do people who in different racial categories have different responses to antihypertensive medication, you might get a yes. If you ask the question, do people with different star signs have differential responses to hypertension, if you have a large enough sample, you might actually get a statistically significant result, but you'd be pretty brave to say that that's how you're going to prescribe. But because it's naturalized in our cultures, in our professional cultures, as well as our social cultures, people take that on as if it has a biological reality rather than a social reality. I will get off just for a second to the next question, but I just ironically forgot the forgotten people that I was going to mention, and just the ones that get left out of everything. Indigenous settlers, so people who are Indigenous in one country but are settlers in another. So I'm thinking of Māori and Pacific Islander people in Australia. Really major, significant, systematic discrimination in terms of access to healthcare and horrible outcomes as a result. And exiles and temporary migrants who have no political no political sway in a country and are therefore expendable and are used to gain political points all the time. Thank you.
Thank you, Chris. Terrific. One of the questions was about the term culturally and linguistically diverse to describe non-white populations in Australia. And the question was, is there a more inclusive term that we can use? I can assure you that's one thing that the Australian Multicultural Health Collaborative is talking about and considering, and that's definitely on the radar and on the agenda for many people. So thank you for raising that. There is no alternative at this stage. And I know even government is also talking about that as well. So thank you for raising that. Delan, this is a question for you. One of the suggested solutions is about racial literacy. So instead of providing unconscious bias training, which a lot of us have gone through, we actively provide examples and ways to analyse how an event, policy and action can be considered as a form of racism, even though they may not fit the narrow legal definition of racism. What are your thoughts on racial literacy?
Thank you. I think thinking about one of the slides I showed with the segment and the different kinds of interventions. Often these interventions, like unconscious bias training, are the most common and popular. They tend to be mandatory, short, one-off sessions and expected to change a society, and usually they don't. So I think moving away from those short lasting individual interventions towards the kinds of things within this question, towards understanding how policies may affect a population, I think that is essential. But I also think we have to look at this at all the levels. We have to target, the actual laws. How do we change laws? So within the UK, we have the illegal immigration bill coming up very soon. There's something that's come out today, just writing about the effects on children and unaccompanied and asylum-seeking children coming to the UK. So I think each individual intervention has some merit, and I think the idea of moving away from the individual to assessments of policies, to understanding how racism can affect the health system is crucial. But we also have to tackle it at all of these levels.
Thank you. Thank you very much for that response. The next question is also for you, Delan, in terms of, you quite rightly told us about those in power who are promoting and exacerbating racism. How do we call that out? How do we make a difference in our society?
That's
well, we booed out Trump for one, but
a very difficult question. But I think
very difficult question.
If I were to think about the role of health professionals and people within the health system, and that's all forms of health protections, health visitors, social workers, midwives, nurses, medical doctors in community and hospitals, health professionals as a group have a position of authority. In most societies, they have a voice. They have this crucial position where they see individual people, they learn about the histories of what's going on a day-to-day basis. And then they also have this position within professional bodies, within institutions that they work in. They have these positions of power. And I think it's important that health professionals realize that position that they have and use that position to advocate for the patients and populations that they look after. They're the ones who see the actual effects of a policy and how it's played out. And I think those stories and narratives are crucially important in counteracting some of these populist tendencies. It's not the migrants that are making people unwell in the UK. It's the government's policies. And the migrants are often people who are trying to help and advance local economies and industries. So I think that voice, using that voice in different ways, and it could be through activism through protests, it could be through publications, it could be talking to your neighbours, it could be having individual conversations. I think there's many levels of advocacy, but I think paramount to this is using the position and authority that you have, counteracting some of these myths with the truth that people see and work on.
Thank you. Yeah, very good response to a very, very difficult question, Delan. So thank you very much. Audience here, live audience, your turn now. Are there any questions? Yes.
I think first my question is asked about the barriers to research. So I guess for Delan and for everyone else, ethnicity data is not collected in Australia. There's no standardized measures for collecting it. All we have is Indigenous status. What is like a way to be able to address this barrier and then to be able to get up this research without the measures available?
Yeah, really good question. So to repeat that in case you didn't hear it, in Australia, and I'm assuming it's the same in the UK too, it might not be, but here we do not actually collect data that enables us to understand the very rich multicultural ethnicity of our people here. And we know that that's a really, really big problem. And it is a problem that we have identified as a issue subsequent to the COVID-19 outbreak. And Mohammed and I sit on a national COVID-19 culturally and linguistically diverse advisory group. And we've been doing that for almost 2.5 years now. I think there's 68 members on that across the country that represent culturally and linguistically diverse organisations and communities. And that was one of the very first things. Do you remember, Mohammed? That was one of the very first things we were jumping up and down and saying, we actually can't even track the outbreak of COVID-19. We won't be able to know how it's impacting on some of our most vulnerable, some of our people that are living with most vulnerability. So they have put things in place, things are clearly going to change. It will take some time, however. But yeah, thank you. It's a really, really serious limitation. And it goes back to my presentation that says in many ways we're still going backwards, not forwards, even though it's 2023. Another question. Yes.
Obviously, white people benefit enormously from the status quo and white supremacy remaining place and they're reduced. So I just wonder about that issue of like power, I guess, and how to, similar to the other question about how to have these conversations and how to change people's conceptualization of their privilege. White people still talking about I want to be, and that's our way to do as white people. About how we sort of address white privilege, white majority, and
white supremacy amongst ourselves. And yes, Chris, yes, I was actually going to ask Chris to answer that one.
That's really topical, always. So a couple of things. One is that you're right, there is actually some ideological work being done in the cause of white supremacy. One of our previous prime ministers is now in the UK actively promoting the policies that he promoted as a leader of our country while he was prime minister. And that is not coincidental with the change in policy in the UK. And there's actually, there's some really interesting work with the Alfred Deakin Institute that was talking about right-wing ideology and sort of populism in recent years. And there is a very coherent, very ideologically, I guess, rich and highly malignant strain of politics, which is quite active at the moment in many countries around the world. And, it's a story that is being told and is quite powerful and is working. And we're seeing some of the health effects of the policies that are outcomes of that. So that's not unconscious bias or anything like that. That's just pure malignant politics. And as a sort of front of store politician who's in Parliament, as opposed to the backroom people who actually make the decisions. Just picking on someone who's defenseless and saying they're a problem, I will defend you all against this person, is just really easy political points to make. And so I think this idea of having professional advocacy and being able to sort of create a counter narrative that's based in the realities of practice, which we can do as medical, other health professionals. People in mental health can do, people in justice, people in education can say, I've seen this kid and this is damaging them. It's really powerful, but we're not really at the stage where we're loudly articulating that, national, transnational kind of level. So I think this series of The Lancet and this work that's been done in different countries is really wonderful development. And I really hope that this goes places.
Thank you. Thank you, Chris. I just was alerted to the fact that the people online can't hear the question. So that was all about white supremacy and how do we ourselves try to reverse that, literally that bias that we have, and acknowledging that we might call it unconscious bias, but the reality is it's real. And what can we do? What can we do to make a difference? So thank you, Chris. Delan, do you have a response to that as well? Or yep.
Yeah, I think I would largely just agree with what Chris was saying. This is important, and it's important for everyone to play their role. I think just one thing to add is that this happens everywhere. This is in every society. Well, not sorry. The current populist governments are not in every society, but it's increasingly common. And there are different groups being victimized, marginalized in different places. But it's important as health professionals to see this and to call it out and to say, this group, these patients who I'm seeing are being adversely affected by this policy. And there are many ways to do that, but I think it's important, and you can do it individually, but being part of a collective of some sort is often a better approach to do that.
Thank you. I know there's a lot more questions, but I can't take any more. I'm so sorry. This has been overwhelming, the response. Lots more questions online, lots more questions, Delan, also in the audience here. Thank you so much, everyone. But because we're literally approaching our finish time and we've only got 5 minutes to go, I am going to call back up Marina to bring us to a close.
Thank you so much, Helen. Look, thank you so much to our amazing speakers. Thank you so much for your generosity, Delan. I think my take-home line from you, if I was a Twitter user, would be, it isn't migrants who make communities sick, it's government policies. That really stuck out for me. Thank you, Chris and Helen, for your fantastic presentations as well. We have definitely run out of time. So there's just a couple of little announcements before we wrap up. Just wanted to remind everyone that we did record tonight. So we will be sending out the recording of tonight. We'll just do a little bit of editing, take out some of our technological glitches to make us look a lot more slick than what we were. And then we will be sending that to everyone watching at home and who are here tonight in the auditorium. If you haven't already signed up, please consider signing up to the collaborative. The website is on the slide. So please have a look at our website and consider joining us. As what we just heard, joining together and collective action is always going to be more powerful than working on our own. So please join us. Secondly, if you haven't already donated to World Wellness Group, you still have a chance to do that. That is the link, and that directly supports our asylum healthcare program, as I mentioned earlier. And the last announcement is that we have very excitingly planning to hold a multicultural health conference, the first. I think in 15 years, we heard today, it's going to be on the 21st and 22nd of November in Sydney. So please join the collaborative so that you get all the updates and consider coming to our conference. So thank you very much, everyone. and see you at the conference. Thank you very much, Delan. Thank you.